Today's topic is going to be on respiratory acidosis. This is going to be a wrap-up of the series of lectures we've been going over in metabolic acidosis, alkalosis. We're going to finish up the acid-base component of this chapter. So, since you've been following this video for a while, this formula is not going to be something new to you. So we're just going to dive straight in there and get into hands dirty, kind of get a feel for what exactly we're dealing with here. So we always talk about definition. Respiratory acidosis. Respiratory, a lot of acids. That's it. Already gave it away. You don't have to crank your brain. Focus on the respiratory part. Remember, the top part of our equation is the metabolic, and the bottom part is respiratory. Since we talk about respiratory acidosis, where we're going to keep our focus, we keep it on the bottom of the equation. I don't want to see you on top yet, except we're compensating. So, automatically what will happen, since we produce a lot of acids, and we talked about in the previous lecture, the only way we get respiratory acidosis, if you're making too much what? CO2. So what do we mean by that? So you're keeping a lot of CO2 in your lungs, right? Most of us, just regular guys like you and me, right? Take a nice deep breath, we blow it out. If we forget to ventilate, which is basically getting CO2 out of our lungs, that means we're keeping it inside the lungs. We don't want CO2 to build up inside the lungs because it's got a couple of bad complications. So, automatically, we're retaining CO2. So, that's called respiratory acidosis. So what we're talking about in this case is that our pH CO2 is very high, right? And what will happen to the pH? It's going to drop because it's what? It's acidosis. So automatically, you should be thinking in your head the pH should be less than what? The normal pH, which is like 7.35. PCO2. Remember, I told you, you got to memorize these parameters. If you don't, you're going to get in trouble. You know why? Because you got to find the primary problem. And the primary problem in this case is the fact that this cute looking lung is retaining the CO2 that's supposed to be blowing out. So what I'm saying is lots of CO2 is building up and they are not getting out. And we're going to talk about why in a minute. So what do you expect the PaCO2 to be? It should be greater than 40 millimeters of mercury, right? And basically we're done. No, we're not done yet, right? Because the body is smart. Although people are retaining CO2, the only way they can get rid of it is by what? Coming up here. That's why we've got the kidneys. So this is nice, beautiful lungs I'm showing you here. Inside the lungs, you're supposed to be having normal ventilation, getting CO2 out, bringing oxygen in. Unfortunately, if you can't do that, the only way you can actually maintain this is by doing what? You have to pretty much use your kidneys. So let's see. The kidneys regulate and fix these problems by using your kidneys, right? And what does the kidneys do? They want to retain your bicarb. Right? Because the only way we can bring up this pH is by increasing bicarb. And we're not going to get bicarb from ordering from the store, right? We're not going to buy from a Chinese restaurant. The only way we're going to get it back into our body is the kidney going to be like, okay, I'm going to retain bicarbonate by reabsorbing as much bicarb to buffer off this problem that we're facing, which is acidosis. So in that case, we can do what? So we can able to increase the pH. But, so the definition of respiratory acidosis, in short, is basically elevated PaCO2 and decreased pH. Now, let's talk about renal compensation in a minute. Renal compensation is going to take a while, guys. It's going to take about a good 5 days because the kidney is very slow. It's a turtle. It's not as fast as your lungs, right? You're constantly, right? If we're hypoventilating and we're retaining a lot of CO2, here's the problem. The kidney is going to try to compensate, but it's going to take a long time. It takes hours. It takes days. By then, people will have died. So we doctors have to come in and fix this. So let's talk about acute and chronic respiratory acidosis. And actually, I don't need to erase anything because we still have some space here. So those are the two types of acidosis, respiratory acidosis we have, right? Acidosis. There is acute and there's chronic. So, in acute respiratory acidosis, this is an immediate compensation, right? Because it's short-lived. What happens is you retain so much CO2 in your lungs right here, and the kidney gets like a little sensor or thermostat. It gets too cold in your apartment. What happens? The AC comes on, the heat comes on, right? If it gets too cold, what happens? The heat comes on. So what's basically the kidney, it's a sensor. It realizes, wait a minute, we're retaining a lot of CO2 and our pH is dropping in the bloodstream. So the acute way of raising bicarb is by immediately doing this. Now, there's a little hint of information you have to know here. And eventually when you do like respiratory therapies, they're really good at this because they do a lot of arterial blood gas. For every increase in 1 millimole of bicarb, right? There's an increase in 1 millimole of bicarb for every 10 millimeter of mercury. So, of PaCO2. Now, I need to explain this so you can understand what I meant. This is where our problem is, right? So basically what the body does is for every 10 millimeter of mercury of increase in PaCO2, there's an increase in bicarb. So basically for every 10 that you increase PaCO2 at the bottom here, there's 1 increased millimole of bicarb. I don't think that's a lot, right? 1 to 10. So let's do a problem so it makes some sense. So John came to the hospital. Is a COPD patient, and this is one of the causes of respiratory acidosis. It's a COPD patient, and he comes to the ER, and he's hypoventilated. He can't get the air out of his lungs, so he's going to acidosis. When we did an ABG on him, his PaCO2 was 50. You guys can assume that's pretty bad, right? His pH was 7.21. From this formula, acutely on his way in the ambulance and they're driving him down. What you guys don't realize is the kidney is saying, well, the doctors are not around to fix this guy, so I'm going to start increasing my bicarb, keeping the bicarb in the body. So for every 1 millimole, 10 increase in PaCO2, so let's say the guy comes, when he was at home, it was 50. When he got here, it became 60, right? And normal bicarb is normally 24. If I check his bicarb, when his PaCO2 is now 60, his bicarb will now be what? 25. That's basically what that means. Now the bicarb is doing what? It's slowly rising. See how slow that is? That's acute though. That is not going to fix the problem because just 1 increase. So that means if this guy goes to 100, that would be 4, right? That would be 4 increase from 60 to 100. That means we're going to get to 29 of bicarbonate. That is not enough compensation for people that are going to respiratory acidosis. But it's acute though. So that's how you kind of do the math. On the chronic side, now when I mean chronic, this is the first, when we start, this guy's his first COPD episode, right? He's been smoking for 40, 50 years, and now he comes in, I can't breathe, I'm short of breath. Well, you're going to be short of breath because you've been smoking, you damage all your lungs. However, 15 years later, after this guy's had COPD for so long, these people retain so much CO2. They don't have the same baseline CO2. Like we normally have 40, they probably had 50 all the time. So the only difference is in chronic respiratory acidosis, what you have to understand is the compensation by the kidneys is different. It takes a while. So the formula basically is for every 10 increase now of PaCO2, for every 10 increase in PaCO2, what will happen is there's a 4 millimole of bicarb. So let's do the math. So if your PaCO2 increases by 10, is equal to a 4 millimole increase in bicarbonate. So what does this mean? This guy is different. This is Bob, that's first onset, acute. In chronic patients, now look at the difference. It was 1 millimole increase in bicarb acutely, but now because the body's so used to it, and now the patient is going to acidosis, now we are taking at least 4 for every 10 increase. So now if this guy PaCO2 initially was 40 and it went to 50, what I will expect is bicarb, which is normally 24, will go with what? 28. Look at that. That's a big difference. A huge jump. So the next 4 is going to be 32. If this guy goes down to 60, right, it's going to be 32. Can you see how fast the body is? But this is chronic. This is not acute. In an acute situation, it's going to be a 1 to 10 ratio. In a chronic situation where patients have COPD, they always coming in, and it's the same story. It's an exacerbation of their COPD. 4. So that's an important concept to understand, to see how the kidneys try to compensate for acidosis in patients with chronic respiratory acidosis. Now, let's now focus on things that are even more important. Now that we already understand, the whole mechanism of acute and compensation and chronic compensations, the next thing we're going to talk about is causes. Now, we always throw words around in medicine. Pisses me off just like it does to you. But hey, suck it up. It's just the way it is. It's a language. There's ventilation, right? And there's perfusion in the lung. I was going to use this guy, but no. So, ventilation means exhaling. Oh, wow, look at that. That was rocket science. You know what? If we had called it, that's the $5 word for exhalation. Or, much better, breathe out. Oh, that just sucks. I can't believe I took like a huge amount of medical student loans to understand that breathing out equals to ventilation. Wow. You know what? If we had said breathe out, then we look like idiots, right? Doctors don't want to use little words. We want to use big words because we don't want the patient to know what we're talking about. Like, oh, by the way, the patient is hypoventilating. What? Wow. Is that a bad thing? Well, you've never heard the word before. You just know. Yes, you just have no idea what we're talking about. But hey, you know what? That's my job. Let's break it down to normal English. So what do we normally breathe out? Last time I checked, it was CO2. So if I'm ventilating my lungs, that means I'm able to what? Breathe out. Look at that. However, there's a catch. You can either hyperventilate or hypoventilate. If this is normal ventilation, look at that. I just had a nice tuna sandwich and it feels good. Well, I'm taking a nice deep breath, right, with inspiration, and when I exhale, I ventilate out CO2. However, if I'm doing this, what am I doing? I'm hyper, right? I'm hyperventilating. What phenomenon did we talk about before in the past that patients used to compensate that cause them to hyperventilate. Well, a lot of things may cause you to hyperventilate, right? If you're running down the stairs and just run like 10 flights of stairs, you hyperventilate, right? Right? But how about this? Metabolic acidosis. Remember? We talked about that. That's a very important concept. I don't want you to forget. So, if metabolic acidosis is hyperventilating, right? What do you think respiratory acidosis is? They're hypoventilating. What happens? They're breathing really, really slow. When I mean that's bradypnea. It's actually a hard word to say. Like bradycardia, bradypnea, like tachypnea. But the problem is they're retaining so much CO2. They take deep breath, but they're retaining most of it. That's what happens to a lot of asthma patients. So now let's talk about causes of it. Now that you understand what hypoventilation is, that's what respiratory acidosis is. That's what causes respiratory acidosis. So all we have to do is just bring hypoventilation of the little smiley face. Actually, they're not smiling, to be quite honest with you. Hypoventilating. And now let's just talk about primary causes. You can tell me this because a lot of your neighbors probably have this, right? First of all, it's probably something wrong with their lungs. It could be a lung problem. If it's a lung problem, what do you think I've been talking about since the beginning? I think I've said it multiple times. If it's a primary respiratory issue, right? What do you think they have? COPD, right? Chronic obstructive pulmonary disease. If you don't know what that is, you should look it up. But we can also make a video on it soon. Chronic, it's a long time. So it's usually people that do what? Yeah, that's why I say they live next door to you. It's probably your friend too. But they haven't developed COPD yet because they're too young. They think they're immortals, nothing is ever going to happen to them. But what did they do? COPD patients, they damage their lungs, right? All those cute looking alveoli, right? Inside their lungs start to get damaged from all the smoking. And what happens? This is what the alveoli looks like. They damage all the walls, right? And it's kind of like their sacs, it's all dilated. They can't collapse. So every time they take a deep breath in, right? They can take a nice deep breath. But the problem is, the alveoli can't collapse. It's always constantly dilated. That's bad. So they what? They're always retaining a lot of CO2 in their lungs. That's bad stuff. We don't want to keep the CO2 in the lungs. We need to get it out. COPD is number one. And you know what causes that? Smoking. All right? How about airway obstruction? What can cause that? How about this? I've got a, 15-year-old kid swallows a coin, right? She swallows a coin, and the coin goes into her right mainstem bronchus and does this. What do you think is going to happen to all this alveoli? They're not going to be able to get air in, and nothing is coming out. Eventually, all the CO2 that's coming from the bloodstream, they're going to diffuse in here, but they have nowhere to go. They're going to develop atelectasis eventually, but they're going to be retaining all the CO2. Airway obstruction. How about if I have a lung cancer sitting right in there, obstructing my airway? I'm going to be retaining a lot of CO2. So, you probably want to remember COPD, but we're not done. How's another way we can retain CO2 in our lungs? Look at this guy I drew here. This little guy. The primary muscle of respiration. The diaphragm. Right. For you to take a deep breath in, what happens? You have a positive interthoracic pressure always in there to allow your lungs to expand and deflate and inflate. However, you have to realize the diaphragm has to has to contract down. Once it contracts down, it allows you to suck in air from high pressure to low pressure. from a pressure of 1 atmosphere to a lower pressure inside your lung, so air can rush down in. However, what happens? What about if your diaphragm is not working? You went on vacation. That would not be cool. Because you know what? Your diaphragm is going to be up this way, and it's not going to come down. So what diseases can affect this? They're called neuromuscular diseases, right? So if you have a neuromuscular disease, like what? Myasthenia gravis. Myasthenia gravis. What is that? That's when you make acetylcholine and you make your acetylcholine receptors, right? So let's assume this is the diaphragm, right? And now at the neuromuscular junction, remember that nice cute little neuron that taught you in neuroanatomy, hopefully you still remember, and all those cute looking receptors, right? If you make antibodies against acetylcholine receptors, that means every time acetylcholine comes out to bind, it can't. So what happens? Your skeletal muscles cannot contract. And all of a sudden, your diaphragm is just sitting there and just staring at you like, I'm sorry, it's not my fault. What happened? You start to retain CO2 because you can't breathe out, right? Because once the diaphragm drops down, you suck air in. How do you push it out? You got a recoil, right? Bam! It's the recoil that snaps back, hits your lungs, bam, all the way out. Okay? How you guys liking this? I hope you're enjoying the show. There's more to the story. How about this? A CNS problem. A brainstem injury. Like a stroke. Right? If somebody has a huge, massive stroke and they herniate their brain, what happens? The brainstem in your brain, right, is where the what? The respiratory center of the body. The primary respiratory center is in the medulla, right? In the brain. So if the brain gets infarcted, right? A stroke, a trauma to it, an injury, what happens? You can't control respiration from the brain. You lose your airway. It collapses on itself. You retain a lot of CO2. You go into respiratory acidosis. That's why we need to intubate. We put a tube inside it, inside your lungs, so that we can what? Help your lungs come in and out. You think we're done yet? No. This is my favorite. It's coming up. I see it all the time in the emergency room. They all come in. Drug overdose. Right? So my buddy, 15-year-old male, I say 17 or 18, been to college, right? Decides to try heroin. Please don't do that. It's bad for you. It's bad for everyone. Don't ever do drugs. Don't do drugs. It kills people. I think that's common sense, but people still do it. It shoots up heroin. Way too much heroin, passes out. No, it's not going to be snoring. It's going to be out completely because heroin, what? Is an opioid. It binds to the opioid receptors in your brain. It causes respiratory depression. Respiratory depression. That means what? I can't breathe out. How about this? That is really, really, really bad. So you get drug overdose from opioids, or too much morphine, dilaudid in the hospital. What do you think? Oh, you're going to knock you out. Yeah, because the CNS is depressed. The brain is what? It's in cool motion. But you know what? You need to keep it active so you can keep breathing out. So you want to watch out for that. So basically, those are the causes. Look at that. It's pretty easy. It could be coming from your brain, right? If the brainstem is not working, if the lungs it's not working right? If you have COPD, you damage the lungs. If the lung is out, if the diaphragm is out. So it's pretty easy. You pretty much don't have to memorize it. But now we've gone through it. Now, let's talk about the clinical features. Right? Just like we always do. That's how we roll in this department. When this patient come in, what do you think they're going to look like? I just told you. They're going to look confused. As the signs and symptoms they're going to present with. They're going to be somnolent. Right? These guys are going to be in coma. Sometimes, right? They might complain of headaches. They might have a headache, right? If somebody has what? Just got into a car accident, bam, hits their heads really hard. The brain is almost shattered. They got traumatic brain injury, right? What do you think? It's going to hurt. You're going to have a headache. So you want to know that. But one key thing that you need to know about retaining CO2, which now brings me to the pathophysiology, because I know we haven't really digged into, we talk about the causes of it, is why is this retaining CO2 too bad? Why? Because increased CO2 in your body, increased cerebral blood flow. A lot of blood flow to your brain, because what? Excessive amount of CO2 vasodilates the blood vessels in your brain. A lot of blood flow to your brain means a lot of CSF production. So you want to know that. Eventually, too much CSF will lead to what? CNS depression. You do not want to see your central nervous system depressed. Because you need, imagine telling, it's like your brain taking a vacation. Your brain's like, oh, you know what? I know you've been breathing for a long time, but I'm going to be back in an hour. Just hold on right there for me. I'll be back. But Mr. Brain, we need you to breathe, so well, I'll be right back. So, can you see that? The CNS is depressed, just have to take a nap. That's not good. That's why excessive amount of CO2 in the brain is bad. What do you think is going to happen if your CSF is too much? Let's take a look at your eyes. You're going to develop what? Papilledema. So if you look at the back of the patient's eye, the fundus disc, it's going to be really what? Huge. It's going to be swollen. It's from all the edema in the brain. From what? Excessive blood flow. That's the big problem about this. That's what we're worried about. You do not want that, right? I hope not. So we've talked about the confused, the somnolent, they have some papilledema. That's pretty much what you're going to see. Now, let's talk about treatment. Right? Let's talk about treatment. What's most important for these patients? Emergency medicine, we always have to look out for this. A, B, C, D, E, right? The first rule is airway. You want to make sure their airway is patent. So we want to check for, make sure they have an airway, because if they don't have an airway, nothing can go out and nothing can come in, right? So you check the airway, make sure this patient have a good airway, right? If they have a stroke, they can't breathe on their own, that's a big problem. Now, these are the key facts you need to understand and you need to know. Now, if the PaCO2 is low, right? So, talking about treatment. So, we check the airway. Make sure the airway is nice and intact. If it's not, we might need to intubate them. So, if PaCO2 is actually less than 60 millimeters of mercury, guess what? You can give them oxygen. Give them oxygen. So when you give them some oxygen, at least they will be able to what? Getting some what? Oxygen back into their lungs. So that's a very key important thing you want to know. But watch out for COPD patients, because these COPD patients, they can also develop respiratory acidosis if you give them too much oxygen. So you want to watch out for that. Now, think about it. Pretty much our goal is to get the CO2 out of their lungs. So all we have to do is what? Just fix the problem. So what are we going to do? So let's start. If the patient had a pneumonia, that's actually, which I forgot to mention, that one of the respiratory issues, if they had a pneumonia here, right in their lungs, and not allowing them to retain way too much CO2, what do? We treat it. You give them antibiotics, they feel better, the acidosis go away, right? If it's COPD, what do you treat them? You treat the COPD, you give them this, corticosteroids, ipratropium bromide, you give them albuterol, you give them some oxygen, you give them some magnesium sulfate, all that good concussion we give COPD patient, and still tell them to stop smoking, right? See how we're treating this? We said, if it's myasthenia gravis, unfortunately myasthenia gravis is really bad, and if they're losing their air, if they start to lose, if they can't breathe with their diaphragm, we have to help them breathe. That's when we take a tube, we open into your airway, we stick a tube down your throat, and we stick them onto a ventilator, and the ventilator allows them, kind of helps them breathe. You get it? Now, you gotta know this. When do we intubate this patient? Remember when I said PaCO2 is less than 60? If it's greater than 60, That's a lot of CO2 you're retaining. We need to intubate so we can get all that CO2 out of your lungs as soon. Hey, thank you so much for watching the video. I hope you learned a lot. Are you studying for the USMLE Step 1 or Step 2? Are you studying for the NCLEX, or you're currently in nursing school as a nursing student? Are you a PA student currently in school or studying for your PANCE exam? Or are you a nurse practitioner student or trying to take your NP board exam? Listen, I've got super awesome content for you. If you truly love this video and it simplified your learning process, I want you to check out my website below. I've listed all the list of exams, whether you're studying for any of this board exam, and all I want you to do is click on the link right now below so that you can take you directly to my website. For USMLE, just go to smashusmle.com. For NCLEX, go to crushnclex.com. And if you're studying for the PANCE exam, the nurse practitioner exam, or you're studying for your internal medicine board exam, just click below and it'll take you directly to ftplectures.com. Listen, I can't wait to help you. If you need to get in touch with me, just get to my website, be able to reach me directly, and we can work together one-on-one. Listen, you're super awesome, and my goal here is to help your dream come true. If you want to be a doctor, want to be a nurse practitioner, a registered nurse, or physician assistant, I'm here to help you get to that next level. With your medical knowledge, let's save the world together. I love you guys. You guys are super awesome, and do not forget to click on the link below to be able to get to my website. Also, don't forget to subscribe to my channel. You guys have a great day. Let's go.